All right. Always fun to have the first session the night or the morning after the party. So good morning. We're going to get rolling here. Sorry for the technical difficulties. So welcome to today's panel, The Right Information at the Right Time, Boosting Comprehension, Compliance, and Engagement. My name is Jordan Stricker. I'm the Director of Ambulatory Strategy for GetWell Network. During today's session, our presenters from mHealth, Fairview, and Secours Mercy Health are going to share their experiences on educating patients with relevant, bite-sized chunks of information, automatically and routinely leading up to or recovering from an encounter within your four walls. For patients and families, this feels like their providers and care teams are holding their hands every step of the way. For clinicians, this is a delightful and scalable way to impress, educate, and manage their patients. Both of these organizations use GetWell Loop to do this, and they're going to share their approaches and experiences today. After hearing from our presenters, I'll open up the floor for questions and to have you guys share your organization's approach to this, so please do make it interactive, ask questions, challenge us. With your participation, this session will provide a great opportunity to exchange ideas and best practices. So it's my pleasure to present this morning's presenters. Dr. Michelle Hughes has been a nurse practitioner for orthopedic and neurosurgery spine for 16 years, the last 11 of which have been at Secours Mercy Health. She is the director for advanced practice for Secours in the Richmond market and is also the clinical lead for virtual health and patient education for Secours Mercy Health System. This role, along with her strong clinical background, has enabled her to utilize her doctoral research on health literacy and apply it across a wide variety of patient education platforms. Also presenting is Sarah Krantz. Sarah has 10 years of experience in healthcare IT, spending the last 2 years at mHealth Fairview on the patient experience and virtual health team. She's responsible for configuring software to meet the needs of the patient experience. She aims to bridge the gap between software functionality and the growing patient needs within the Minnesota Twin Cities and surrounding communities. But before we get started, standard disclosure here. I need to talk to you about the Maryland Nursing Association as an accredited approver of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. If you wish to receive credit for attending this activity, you must complete the session survey found on the conference mobile app. In the survey, it is important that you check the box indicating that you would like to receive credit and enter your full name and email address in the space provided. Your certificate will be sent to that address. In compliance with the continuing education activity credit, conflict of interest disclosure statements, we'd like to announce that the presenters of the session have no commercial association that would create a conflict of interest. It's a mouthful. All right, let's get going. Thank you, guys.
Thank you, Jordan, for that introduction, and I am so excited to see all of you here this morning. I was a little worried because it was a fun night last night, so thank you for being here, and I am really excited to share the work that I've done for many years in health literacy and specifically with Loop at my facility. So it's been fun to prepare this presentation for you and to try to get it into a 15 to 20 minute presentation. I'll be honest, it's quite hard, so I'm going to speak fast, and if I need to slow down, just kind of wave at me and let me know. So what I am going to talk to you specifically about at first is some of the work that I've done on health literacy and how that differs from functional literacy, because a lot of people don't really understand the difference there. The adult learning theory, the way that people learn and the modes of learning and barriers to learning, and then how we utilize the Loop platform to sort of mitigate those barriers. As Jordan said, I have no conflict of interest. This is just a diagram of where I work, Secours Mercy Health System. We're 48 hospitals and growing in the U.S., over 1,000 practice sites in the U.S. and in Ireland. So we are definitely a growing healthcare system that are using the Loop platform. And I'm in Richmond, Virginia, which is right there, not too far from where we are now. I'm at Memorial Regional Medical Center, which is in the suburbs of Mechanicsville, just outside of Richmond, Virginia. I work in a 225-bed facility. It's a magnet nursing facility. And again, I work in orthopedic and neurosurgery, and that's my clinical practice. And in my spare time, I do a lot of work with the Loop platform and in patient education. So why are we here? And we've heard a lot about this throughout our time at this conference and just in talking with everyone else. We all have the same interest in making sure that our patients are getting information in a way in which they can really digest it and be able to utilize and comply with the information that we're giving them. But typically in a healthcare setting, it's very confusing, and it's a stressful time for patients. So we're throwing a lot of information at them in a very complicated process, and they're basically drowning, and they're needing our help. We often are giving mismatched communication. Providers, clinicians don't often talk to each other well enough. The electronic medical record has removed a lot of that interpersonal collaboration, and so we need to really take care and make sure that we're doing right by our patients. Back in 1970, the American Hospital Association created a document called the Patient Bill of Rights. So for over 50 years now, there's been a document that said that patients need and deserve relevant, current, and understandable misinformation. And I would argue that to a degree, we've missed that mark for over 50 years, but I do think that digital technology is going to help us bridge that gap. So functional literacy, basically that's defined as being able to read and write. But taking that a step further, being able to read and write and actually make that actionable steps so that you can perform daily tasks and negotiate everyday life. In the US, 1 in 7 Americans read at or below the 8th grade reading level. And so when people think about functional literacy, they think about reading level, but it's definitely more than that when you're talking about healthcare information. This was also an interesting statistic, and this has improved since 1996, but prior to that, high school dropout rates were higher than almost 20%, and now we're at about 7 to 8% because of a lot of the work that's being done there. But that contributes to the potentiation of further functional literacy deficits. So functional literacy doesn't equal health literacy. Health literacy is a little bit more than that. It's the ability to process the information that we throw at them, that mismatched communication, and be able to follow the instructions that we're giving to them in a stressful environment so that they can make decisions on their health care and be able to act on that, and to be able to navigate our very complicated system as well. So illiteracy basically is going to create a myriad of problems for our patients. They're not only not going to be able to necessarily read the information we give them, they're not going to be able to understand it and comply, they're not going to be able to navigate the system, and there are tons of great research articles out there that are saying that patients who have illiteracy deficits have complications, blood sugar control, readmission rates, which is definitely a big concern for a lot of hospitals, that up to 50% or higher of readmission rates in those that are illiterate. So I thought about what would this mean for somebody that's not a clinician, and I thought, okay, I know how to read the medical jargon, but what I don't know anything about is how to fix my car. So I thought, okay, a head gasket, I've heard that term, what is a head gasket? So I Googled some information about like, okay, these are the instructions on how to change a head gasket, and I see words like head and block, feeler gauge, mounting surface, bolt and stud holes, bolt torque. And I was like, okay, that means nothing to me. Let me look at a picture of a head gasket and see if that makes better sense. That doesn't. So I'm like, okay, this is how our patients feel. And even some of the pictures that we give them are very complicated and don't really explain what they're looking at. So I think it's important, again, to think about the Bill of Rights and think about who we are as providers, healthcare people in healthcare, and as clinicians. And certainly as a clinician, my primary role is to be a clinician, to be at the bedside and to take care of patients. But I also am a researcher, I'm a consultant, I'm a leader. But I think too that the primary role that we often don't utilize or appreciate well enough is that we are educators. We have to talk to our people and get them to the point where they're understanding the basics of why they're there and what they need. So we need to make sure that we are delivering care to everyone, that regardless of their literacy and comprehension, but try to treat everybody as if they have limited health literacy. You can't tell by looking at them. Whoops, sorry about that. Can't tell by looking at them. Literacy skills also don't mean that they have a great understanding. You know, if they have a doctoral degree, it doesn't mean that they're going to really understand what you're telling them. They're in an anxious situation, they're sick, they're not feeling well, they're scared. That's already going to decrease their ability to comprehend and to listen to what you're saying. And everyone's going to benefit from clearer information. So when I was doing my research on this, I really leaned on Malcolm Knowles' theory of adult learning, and I'm not going to go into a whole theoretical lecture here, but basically it talks about centering your education in the way that you approach people so that you're meeting them where they are, centering it on their life circumstances and individualizing it as best as you can, building the information that you're sharing with them on their current knowledge base. So really assessing what do you understand and what are your primary questions. And the other key thing here is what has driven a lot of the way that I've revised and used some of the loop content is that patients need and will learn, adults particularly, will learn what you're going to teach them if they understand why. They want to understand why they need to know something before they're willing to open their brain and wrap that around what you're telling them. And they want to be engaged, and it should occur in a comfortable setting, which, as you can imagine, Loop platforms at home couldn't get more comfortable than that. And this is the diagram I created for the adult learning theory, and I'm not going to go into too much detail, but again, you need to talk to patients about why they need to know something, what's their self-concept and their orientation and the foundation of knowledge that you're building off of. What is their readiness to learn? And I'll talk a little bit more about that piece. And then what's motivating them to actually listen and carry through with what you're telling them. Geriatric patients are a big part of my population, and Sarah will talk about her pediatric endeavor here, but geriatric patients come with a subset of problems of their own. They're cognitive, they may have cognitive deficits, sleep disturbances, muscle mass, so they can't sit upright, they may not be able to access a device, bowel, bladder, visual changes, hearing loss. All of these things impact how they are able to absorb and hear the information. And level of wellness, if they're not feeling well, if they're in pain, nausea, if they have fatigue, if they're stressed or otherwise distracted, those are things that are going to change the way they absorb. And then we've also heard plenty of people, which I was happy to hear throughout the conference, talk about the social determinants of health, because those things play a real factor in where patients are when they come to you. Maybe they didn't come from a community, so if we talk to them about eating healthy and good nutrition, well, they may not come from a place where they can get good, healthy vegetables to eat. Things like that, so you need to make the information and the instructions realistic to their circumstances. Barriers to learning. I would argue that we are probably the biggest barrier. We haven't met that call to make sure that patients are getting reliable information. We're moving in a very fast-paced environment, and as clinicians, we're just constantly on the go. So we need to make sure that we slow ourselves down and really, again, meet the patients where they are. There are tons of other clinical setting barriers. The information's too much. It's overwhelming. It's complex. It's not complete. We think it's complete because we know what we're saying, but it may not be complete for them. The way that we deliver it in a healthcare environment, in a hospital, it's busy, it's loud, there are a lot of interruptions. I know that when I talk to my patients, volunteers are coming in and out, phones ringing, things are happening. There's fast turnover for patients in a hospital. We're trying to get them in, get them healthy and stabilize them and get them out. And then often patients aren't ready. There's some patient barriers or families not present, and that's important to have and include in that education too. There are 4 primary learning styles for adults or for people in general. There's auditory, so hearing, visual, reading and writing, and then doing. And this diagram is a little busy, but basically the concept here is that if you have them, if you read it to them, they're going to retain about 10%. But if you read it to them and they're looking at it and they're hearing it from you, they're going to comprehend a little bit more. But if you're doing all of those things and you're doing teach back and return demonstration, the more of those modalities you use, the more that they're going to comprehend and retain. Visuals are helpful. 60% of the population consider themselves visual learners. I'm one of those people. If you tell it to me, I'm not going to hear it and understand it and retain it as well as if I see it on a piece of paper or in a diagram. So visuals are really helpful to be able to connect that with the written information. And if you think about typical patient education materials or discharge instructions, those kinds of things don't usually come with great visuals. The electronic platform really helps to open up some of those opportunities. Other tips, use plain language, limit the information, chunk the information into bite-sized pieces. 3 to 5 points is what literacy standards recommend. Make sure that it's specific and concrete, repeat, use teach back, be positive and encouraging. When I was doing my revisions before we had the Loop platform, I used this tool. It's called the SAM tool, or the Suitability of Assessments and Materials tool. And it focuses on decoding words, comprehension of the patient, making sure that they're understanding the meaning and the intention. It's a good fit for them and it's tailored to their population. And it looks at this is the scoring sheet. You don't have to read the details here, but basically I had to go through in our written instructions for my patients, looking at content, literacy demand, which is that 8th grade or 5th grade reading level is what's recommended actually, graphics, layout, the learning motivation, and then again, the cultural appropriateness. And after revising that tool, the pre and the post, it was quite astounding that we thought we had great materials, but we really were not meeting standards. And after the revision, we were able to prove an improvement in outcomes. I'm sorry about the layout here, but this is another tool that a lot of our content people that I've talked with here at the conference are utilizing, PMAT, and that's endorsed by the AHRQ. So enter GetWell. I did a lot of manual revisions on our content, but GetWell is a great platform to be able to meet the patients across the continuum of care. It's daily touch points. It's just in time. And the nice thing about working with GetWell is that it may be the default the default material may be in just-in-time information, but if your patient's journey is a little different, we can modify that to make it meet their journey. It's coordinated activity feed, so it's not just a textbook or a book of information. It's bite-sized information and little things where they can read, or a pop-up menu, or a question that they can answer so that you're validating that engagement there. It's an opportunity for patients to get some proactive answers to their questions instead of calling into a clinic setting. They get information that's always available to them. So if they've already reviewed today's check-ins and activity feeds and resources, they can go back and see some of these things. There's checklists that are promoting their self-management, so it's engaging them and motivating them, and it's giving them a to-do, which is a part of that brain that they need to be able to comprehend where they are. There are automated assessments so that we can monitor their symptoms and identify any areas of concerns through an alert system. So again, the check-ins monitor engagement. It's real outcomes. It's optimizing patients before and after surgery. And then one thing that we have noticed in the implementation of our phone calls, our platforms, is that it's limited phone calls to the office, so that there's fewer unnecessary phone calls because the loop material's there and at their fingertips. It helps to improve communication, and it shows engagement of your healthcare team and the providers with the patients too, so they feel like we're a little more tangible and a little more readily available to them through this platform. So it's promoting their satisfaction, their knowledge, their comprehension, and hopefully their adherence too, because if they feel engaged and they feel that we're engaged, they're more likely to comply and listen to what we're telling them. Bidirectional communication is one of my favorite components of the Loop module. It does take some pushing of the providers to really get them to want to commit to have the staff to engage with this, but what I have been able to sell in a way to them is that it's, again, going to decrease phone calls to the offices, but it's a way for us to really stay in touch and to use the information in the platform to its truest intent, so that when there are alerts, we're being actionable on those alerts in more real time instead of there being a delay. So there are different levels of alerts, and certainly the red ones are the ones that we're most concerned about. These are the modules that we are currently working on or live with at Bon Secours Mercy Health. Total joint replacements, which is my area of specialty. I'm working on spine modules as well. We have bariatric surgery, enhanced recovery after surgery or with colorectal surgeons, TAVRs. We've looked at CHF, pediatric endoscopy. So those are just the highlights there. Revision steps, and that's another part of the process that I wanted to kind of share with you, is my journey with GetWell and implementing our Loop modules. So we took a lot of our current content, we have classes and books, and we were able to kind of merge that with the default content that was offered to us through the GetWell network. We were able to brand and customize it, which is important to any facility or practice. And then with the revisions, it started off with having PDF files where we went from having digital material into a paper version, and I was using pages and pages of a paper version to make revisions, and then the GetWell team would have to go back and put that back into a digital world. As you can imagine, that's a very cumbersome process. So they heard me loud and clear and have worked really wonderfully with me to sort of pilot other opportunities to do that in a more efficient and effective way. So using an Excel spreadsheet has been an electronic way that I can help make revisions. And trust me, I have lots of them because I'm looking at every single word and every single sentence and structure. So again, we had, and for the total joint module, we had 61 pages of PDF documents, page after page, that I was going through and chicken scratching all over, and it was definitely cumbersome. So the nice thing about being able to do it electronically is that I can more adequately revise the content, but also the journey. I need to be able to make sure that the pieces of information are at the right time, and that it's following the patient along in their journey and where they are. So these are examples of how you can do that, and you can decide when they're going to get that information, which is that middle column on 10 days before surgery. How many days in a row do you want them to have it, and for how long of a duration do you want them to have that information? Videos, visuals there's a great library full of videos that they can link to, and I think the Masonic Children's are going to talk about some of that as well. Rewriting resources, so there are resource tabs that patients can look at, and we were able to kind of utilize our brand and some of the things and give patients one-pagers that they can click on in the columns and see throughout their journey. And then, of course, with any initiative that you work on, you want to make sure that what you're doing is actually having an impact on your patients and your outcomes. And so these are just a few of them. And we've heard about the great outcomes. I know Todd was talking about the great things in the general session, and those are good, but we need to be able to make sure they're real to us. Engagement's important, so activation rate, utilization rate. But at the end of the day, do those really mean compliance? Do those really mean that we're pushing patient outcomes and changing the way that they are recovering from their procedure? So we're looking at other things. We're looking at patient satisfaction, readmission rates, length of stay, surgical site infection, home health utilization, trying to prepare our patients to be able to care for themselves in their own home environment, hopefully with fewer resources. We've got to be good stewards of the healthcare dollar. So lots of ways that we're doing that, and working with Loop to be able to create impact reports so that we can really track the actual outcomes of our patients with the data that we have. Because so often we are data rich and information poor, right? We've got a lot of data, but what does it really mean? So future state, we're hoping to interface with our EMR, looking at patient-reported outcome measures, and looking at how we can utilize this to support some other reimbursement through CPT codes by utilizing the virtual health platform. So I'm going to turn it over to Sarah, who's going to talk about her opportunities.
All right, thanks, Michelle. So I'm from the University of Minnesota mHealth Fairview. So we're a large organization up in the Minneapolis Twin Cities area. And specifically today, I'm going to talk on behalf of Masonic Children's Hospital, our pediatric organization. So we're talking about that right information at the right time. Masonic Children's Hospital is a 246-bed comprehensive children's and mothers hospital. We have been on the GetWell inpatient since 2011, and then GetWell Loop was previously GetWell Go, kicked off in 2017. And so now we're fully on the Loop platform, and we piloted with our general, our urology, and our neurology surgery departments at Masonic Children's Hospital. Similar to Michelle's concepts, we did a lot of work on the design thinking and the care philosophies that are important to Masonic Children's Hospital. And one of the big things we did that was through our patient and family-centered care, so involving our patient advisory committee in the process to make sure that we are thinking about what information they are expecting to receive from us and the information that was helpful to them throughout the process. We also did factor in the human-centered design process as well, so that we could make sure that we would focus our attention on those aspects that Michelle kind of talked about in her presentation. So I'm not going to delve too much into that critical design thinking process, and more so I'm going to kind of talk about how we took then our content that we created and put that into our Loop platform. So one of the big things after we made sure that we included the patient in the experience, we also decided that obviously the care team was an important factor in making sure we're giving them the right information. So we wanted to make sure that we had the surgery preparation that we would need in order to avoid our cancellations. So that was our big goal. And with that, we did a few special things. We did videos, children teaching children. So we thought this was really important, and as a pediatric facility, to make sure that we were focusing our attention on that child education. This is just kind of a few snips of videos just to show you our content that we created. So there might be some jumps.
Hello and welcome to the University of Minnesota Masonic Children's Hospital. You probably wonder what the surgery center will be like and what happens on surgery day.
Hi, I'm Annabelle.
Hi, I'm Malachi.
We've been here a few times ourselves and know that sometimes new things can make you feel worried because of all the questions you might have. It is always okay to ask questions. We made this video to help you understand what to expect on your surgery day and things you can do to get ready. We hope this video helps you.
It makes you feel better.
It is important that your body is clean before surgery. Your doctor may want you to wash with a special soap. Surgery, you won't be able to eat or drink like you normally do. This is a very, very important rule. After a certain time, you can't eat or drink anything.
Your tummy needs to be empty before you have surgery.
A nurse will call. Then you will check in at the lobby desk. The people coming with you must get an ID sticker. There are 4 places you will visit in the surgery center. The first is the welcome lounge. There you check in. The second place you'll visit is the get ready room or preoperative room. The people here will be wearing. Your nurse cares a lot about you. They will answer your questions and make sure you are ready for surgery and that you feel comfortable. Oximeter, a special red light to shine on your finger and measure how your heart is working.
It's like giving your arm a hug.
A child family life specialist is there to help kids like us feel comfortable and help us understand what is happening while we are at the hospital. Next, you meet with your doctors and other important members of the surgery team. A surgery doctor is called a surgeon. This is the person who will perform your surgery. Surgeons are special doctors who care about making. A sleep doctor is called an anesthesiologist. They care about you and make sure you are comfortable and asleep during your surgery.
Sleep medicine keeps your body asleep during your whole surgery.
Your doctor will talk. There are different ways for your body to get the sleep medicine. You might breathe medicine through a mask.
You get to pick your favorite flavor.
Or we might give you the medicine through an IV. The next place you will see is the operating room, called the OR. When it is your surgery time, you will ride on a bed to get there. This is what the surgery rooms look like. The last room you will see is the wake-up room. After your surgery, it is normal to feel some pain. Pain is one of the ways that your body tells you where it is trying to heal. Your job is to tell some children go home after surgery and some stay in the hospital. Your doctor will decide if you need to stay or if you can go home.
Now you're all done.
Good job, you did great. Thank you for joining us. We hope this has been helpful. Remember, if you have any questions, be sure to ask.
See you soon.
So yeah, that content designed for children was really important for us, but also we wanted to educate the parents as well. So the next slide talks a little bit more about how we focused our attention to the parents by giving education from the nurses and the surgeons directly. So here's another grouping of clips that we chose to use for our family caregivers content.
Hi, I'm Carla. This video will talk you through your child's surgery experience. Please bring with you a list of your child's current medicines. Be sure to note, call the surgery center if your child has a rash, cold symptoms such as runny nose. It is important that your child's comfort items are clean if they will be bringing them along to surgery.
Infections after surgery are extremely rare. However, we have learned that many of the infections that people do get after surgery come from germs that are already on their body. You can help prevent.
Age and surgery will affect when he or she needs to stop eating and drinking. A nurse from the hospital will call you 1 to 2 days before your surgery to ensure that you know exactly what to do so that your child is safe. There's a lot you need to do, and you are not alone in this process. You will get 2 separate phone calls. Your child's surgeon will be there to answer your questions and request that you sign surgery consent forms.
Many parents have questions about anesthesia. How will their child be given anesthesia? Will they be with their child as they fall asleep? Your child may get anesthesia through an IV. We also understand how important it is that your child feels safe. Your anesthesiologist will talk with you about the best plan for your child during surgery. It is sometimes possible for a parent to be with their child as they fall asleep. We call this.
After surgery, the doctor will talk with you and let you know how the surgery went.
After surgery, pain is normal and is an important way that your child's body tells us how and where it is healing. We want to be sure that
We're all here to help your child feel comfortable with the surgery experience.
So you'll notice there that we did a good comparison between what a child might want to hear versus what a family might want to hear. You'll notice there's some different music, there's some different concepts that we focus on, so it's an important factor to know your audience.
Hi, I'm...
Excuse me. So just to give you a quick overview of what our pathway looks like in GetWell Loop, we have a minus 21 day, so about a 3-week loop. We focus a lot on having child-specific content kind of at the beginning so that the parents can prep their children. And then closer to the tail end is when we get into that more detailed information about what they should expect from the pre-admission nurse calling them, what kind of showering or NOP protocols that they're going to have to follow suit with. And then obviously the day before, they're checking their cold symptoms. They're making sure that they have all the information that they need, like their GPS instructions. We have a lot of folks who come from other states in order to get surgery at the Masonic Children's Hospital. So it's really important for us to make sure that people have the right information so that they are not late to their surgery, so that they feel comfortable and prepared for their surgery day. And how the parents access this is all through the Loop platform. And if you're familiar with Loop, families would receive either an email or a text message with the information that they need in order to get into their pathway. That pathway would then be that comprehensive accumulation of all the information that they received along that 21-day journey prior to their surgery. So our current or pilot workflow that we processed was that a scheduler or a CMA would introduce and invite the patient. So this is all a manual process at this point in time. So we have our clinicians actually taking the time to set them up in Loop. So logging into Loop, getting their email in there, and kicking off that activation process. They might even in the room ask the parent to actually click the activation so that they are actually in and signed in and have no technical difficulties. And then the family can choose to activate or not if they hadn't done that in the room. And then of course the family has a choice to view that content or not. And then from there, we had a pre-admission nurse calling the families about 2 days prior to the surgery. And with that, the patient would then arrive for the surgery day, hopefully prepared. We learned that within our large system, there's a lot of factors that play into this process. And so in a couple of minutes here, I'll talk a little bit more about the new staff workflows that we're gonna process through. But just some outcome metrics for you. We have some patient statements here, so some examples of what we were hearing after we went live with our health loop or GetWell loop. A lot of the feelings that we got were that the information was helpful. It was the right information. It was bite-sized. It was the right information at the right time. And then the fact that they could always go back and reference those materials was just such a huge thing for the parents. So even when they knew what to expect as a parent, it was helpful for them to maybe show those videos to their son or daughter. And then of course the constant text messages to remind them to do their checklists or to get that information was also really helpful. So what we were really trying to accomplish with our outcome metrics were Loop trying to eliminate or completely help our preventable reasons for cancellation. So you'll see here there are certainly things that we can't prevent or we can't help, but the ones that we can, we want to address within the Loop platform. So for our pilot, we did those 3 surgical services, and while on a given loop, we had no patients that canceled due to preventable reasons. So that was just such a huge motivating factor for us, and we continued to move forward with even better activation in the GetWell loop. But again, reminder, this is all a manual process. So they're kind of hand selecting, or it's based on if the clinicians have the conversation and the patient seems interested. So we're kind of getting a population of people that are usually excited and geared up for it. So what we've thought a lot about was next steps. So what's really the best way to have that consistent trigger? We have a complexity of 6 different types of employees that would potentially schedule in Loop, and we found that there's just so much variability in that. And because of that, it's too hard to maintain that training process to get everybody up on a loop by having to do that manual intervention. So of course, everyone is scheduled for surgery in our Epic system, so why not use that as the constant trigger? So we are moving forward with an interface with the auto enrollment. We've done in our organization, not pediatric, 3 other pilots that were successful on our interface. So now we're getting pediatrics up and running on that interface as well. And what we want to continue to explore is, although we want to utilize that technology and we want to continue to have those efforts where we streamline the process and optimize as best we can, we also want to know what that appropriate human factor is as well, because we are here for the patient care. We also thought, well, that pre-admission nurse calling about 2 days before surgery might not be enough time. We find that we run into a lot of challenges with like guardianship paperwork and things like that that may just not be able to be figured out within those 2 days prior to surgery. So giving the patient a little bit more time to process that would be helpful. And then we hope to expand, of course, with our other pediatric avenues as well. So here's kind of the takeaways. Some of the things that we've learned is that really the surgeon needs to be involved. So the surgeon is the one that needs to set that groundwork for the rest of the pathway and let them know that important factor and what value they're going to get out of hearing this content, and really to get to that point of your child's surgery may be canceled if we don't follow these instructions. And then by eliminating the clinical staff from having to do that registration process, we're having our normal schedulers book their surgeries within Epic. And then, of course, that family can choose to activate or not. And so that's when we're kind of thinking, is there another human factor here? Is this when we take our clinician time and try to insert that into the pathway so that we can say, as a reminder, this is really important information. Have you just forgotten? You know, is it that the families are too stressed out? Was it that initial feeling of my child going through surgery was too overwhelming? What was it that maybe stopped them from continuing that activation process? And then having the pre-admission nurse preparing the family for surgery maybe closer to 4 to 10 days prior to surgery so we can avoid any of those challenges that we might run into really close to the surgery date. And then, of course, we're hoping that patients arrive for their surgery without any cancellations. So we want to explore those cancellations that did occur, why they didn't sign up for Loop, some of those other caveats, those socioeconomic factors. So was it a language barrier? Was it the technology fear? Was it challenges that they had? Since it's all going to be that automated process and we're not having someone handhold them through that process, I think that's a really important factor. And then engaging both parents in Loop when there's a shared custody situation. We're right now just putting one parent in the loop. We'd like to see multi-families, multi-caregivers and families have that shared ability. And then, of course, video options and pathways for specific surgery cases. All right, thanks everyone.
So we have time for just a couple questions for Dr. Hughes and Sarah.
This question is for Dr. Hughes. I just briefly glanced at your list of measurement tools that you were looking at. Did you ever consider measuring or explain things in a way you understand under the HCAP questions?
Yeah, oh good, this is working. Yes, absolutely, and actually that's part of what my dissertation was on. We looked at the care transition domain questions for the HCAPs, which is how well did I understand, and then we also looked at readmission rates and saw it absolutely made a huge difference. And I'd be happy to share some of those outcome measures. That's more specific to my actual research prior to Loop, but the concept is the same, absolutely. Mm-hmm.
Any other questions? Here.
The videos that you showed, so are those spread out inside the Loop?
Yeah, they are. So just that child teaching child, that one was a variety of clips from one video. So we do have some content that is kind of more robust, I guess you would say, so that they can actually hear the process. But then we also have small video clips as well that are kind of shorter and talk a little bit more about like specifics. Like, here's an example of what Masonic looks like, our campus, and kind of gives a little bit more feeling for those aspects that they might be looking for. So yeah, some of it's broken up, some of it is more kind of robust content so that they understand the process.
All right, we're gonna allow one more question.
Hi, ladies. Hi. Sorry, I didn't mean to, that was loud. Thank you for your talk. You both did great. Sarah, I just want to say, don't fear the automation process in taking the front end out of that. It's still, I feel like this is so good. If anyone comes to this and then comes to mine this afternoon, it's like a great segue and I think we bookend this nicely. But I just wanted to tell you, we kind of accidentally went live with one of our loops, and it was set up for automation without the prep from anyone else on the care team, giving the patient and that information ahead of time. We had people activating.
Sure.
So don't fear that, because sometimes, it's just kind of natural. And it depends on if you're doing provider branding or what have you. We've had better outcomes with provider branding, but I think the automation is a great next step for you guys. You guys are doing some great work.
Thank you.
So thank you. Yep.
All right, we want to be sure to get you guys off to your next session, but just a reminder that these slides will be posted on the client community within 30 days. So if you need access to that community, your client service manager can give you information.